Our first speaker is Dr. Mark Ferguson. He completed his medical education and postgraduate training at the University of Chicago Hospitals, where he is also professor and head of the Thoracic Surgery Service and program director for the Cardiothoracic Surgery Residency Program. Dr. Ferguson.
Great. Well, I can't tell you what a pleasure it is to be able to join you here. And my thanks to Drs. Kyler and Einstein for the kind invitation, and to Jerry Tatar and the Tatar Family Foundation for sponsoring this. I think it's a great concept. I hope that you all will learn a lot today, and I'll be looking forward to interacting with you during the question and answer session. So I've just laid out some goals here, which I think we'll be able to cover adequately. This is an outline of what we're going to be talking about: trends in staging, advances in risk assessment for potential surgical patients, the ways that we surgically personalize therapy these days, some of the advances in surgical technology that are currently happening, and what we can look forward to in the very near future, and how some of these things are influencing the practice patterns of surgeons. And as opposed to the other two talks, Jerry, I think you'll find that this one is immediately accessible to you. So just to lay a little bit of the groundwork, this is the magnitude of the problem of cancer in general in the United States. As of 2013, you can see that the incidence of cancers among men and women is very high, and the mortality rates for lung cancer for men and women exceeds the next three solid tumors combined. So this is a very important problem. And as Jerry Tatar pointed out, the Institute of Medicine this morning released their summary on cancer care in the United States as it currently stands, and calling this a crisis because of the decreasing numbers of physicians specializing in this, the substantial increase in cancers that will be seen in the next 17 years. It's currently at 4%. It's estimated that that will increase by about 50% in the next 10 to 15 years. And moreover, the complexity of the knowledge base that's required to manage these problems is increasing. So they're encouraging substantially more data collection, more systematic data analysis, sharing the data, multi-specialty care, and things of this sort to improve cancer care. So with lung cancer in particular, we're faced with the problem of large numbers at each end of the spectrum. So most of the surgical patients are going to be stage 1 patients. The majority of patients overall are more advanced tumors. So staging is very important at the time of diagnosis because it's very directly related to survival. Localized cancers have a very good cure rate, whereas distant spread of cancer is associated with a very poor cure rate. So this has a lot to do with screening, early detection, and effective therapies. We'll be talking about staging and treatment for this first 45 minutes or so. So the traditional methods of staging lung cancer, CT scan and PET scan, as you can see, have fairly good negative predictive value when used together. And so that's a good way for us to screen patients who do not need further staging. Unfortunately, the positive predictive value is not nearly as good. So if we see abnormalities on a CT or PET, it's incumbent upon us to do invasive staging of these patients to get a more accurate idea of what's going on. You can see the summary here: negative predictive value, quite good; positive predictive value, not nearly as good. So we think this invasive staging is quite useful for patients who have central tumors, bulky primary tumors, advanced T-stage of tumors, and clinical evidence for either N1 disease or N2-3 disease. We're seeing a change in practice patterns over the last 5 years, and I think this is going to continue to evolve over the next 5 to perhaps 10 years, where more non-invasive or minimally invasive staging is being used for patients with potentially resectable lung cancer. So in our institution, for example, the majority of patients initially undergo endoscopic ultrasound, EUS, or more commonly EBUS, bronchoscopic ultrasonography, for staging the mediastinum and the hilum. And then when this is incomplete or unsuccessful, then we will do more invasive staging, such as mediastinoscopy that you can see here, occasionally thoracoscopy, or at last resort, thoracotomy. You can see the representative ability of these various staging modalities: transbronchial needle aspiration, EBUS, EUS, VATS, and thoracotomy for staging these various mediastinal stations. And these very invasive treatments are quite good, but probably too invasive for most patients. We're looking at these transbronchial means of accessing lymph nodes for the majority of patients, and then only turn to mediastinoscopy in very select instances. We're still having challenges staging levels 5 and 6, and so we often have to go to thoracoscopy to stage patients who have abnormalities only in those areas. So for mediastinoscopy, the traditional way, we can look at levels bilateral upper paratracheal, lower paratracheal, and the subcarinal lymph nodes. You can see the advantage of these more minimally invasive staging techniques. EBUS can get all of the things that mediastinoscopy achieves, as well as looking at hilar lymph nodes. And EUS adds, in addition, sometimes levels 8 and 9 lymph nodes, the paraesophageal and pulmonary ligament lymph nodes, and rarely can get to the aortopulmonary window lymph nodes, level 5 lymph nodes. So sometimes a combination of these is necessary to achieve accurate pathologic staging of the mediastinum before treatment recommendations can be made. So as I said, we're sort of in a transition period right now where the skill set is being developed for interventional pulmonary and to some extent GI in performing these tests. These relatively recent data demonstrate that the overall utility of mediastinoscopy still exceeds EBUS and EUS in an all-comer sort of situation, and we're anticipating that with additional experience and perhaps improvements in technology, these false negative numbers will continue to drop, perhaps equal those of mediastinoscopy, so we can start to eliminate some of the more invasive staging procedures for the majority of patients who are potentially resectable with lung cancer. So you can see currently this head-to-head comparison of EBUS versus mediastinoscopy, a lot of statistically significant differences favoring mediastinoscopy totally. What this suggests is that we need to choose the right technique for mediastinal mapping in order for us to make the appropriate treatment recommendations. So this is the current algorithm that we use. At our institution, it's one that's been codified in a set of guidelines by the European Thoracic Surgery Group. Well, we'll start with these radiographic tests and then primarily use EBUS and EUS to stage patients. When that's incomplete, then we'll use mediastinoscopy in order to make the final determination for resection versus induction therapy or non-surgical therapy. This is a little bit complex, but I think you at least get the idea about the algorithm moving through less invasive towards more invasive before a final recommendation is made. So let's talk a little bit now about how we personalize selection of patients for surgical therapy. The problem with doing surgery on patients is it puts them at risk for mortality. Fortunately, the risk rate is relatively low. And for a variety of complications, cardiovascular complications in 10 to 15% of patients, pulmonary complications, 10 to 15% of patients. And this is from a recent summary from the Society of Thoracic Surgeons database, which now has something like 30,000 major lung resection patients over a period of a decade. So it's quite a powerful tool for us to analyze outcomes and how we can improve the patient experience. Pulmonary complications, as well as cardiovascular complications and others, are quite important in determining costs of care and ultimate outcome. You can see the patients with complications have substantially increasing costs and increasing mortality. So our job is to assess risk on an individual basis. And it's quite easy to identify patients who we think are probably at typical risk. And it's more difficult to select out those patients who are at increased risk but are still potentially operable. And then finally, telling patients no, those who are at prohibitive risk, becomes problematic. The more objective we can make this assessment, the better. It's more satisfying for the patients. It's much more satisfying for the treating physicians. So a couple of recent advances. This is a summary of some work done over the last 5 years or so. So the traditional way that we assess patients from a cardiovascular standpoint is to use the relative cardiac risk index. And this was developed in '77, published in the New England Journal by Goldman and others. And it was updated in the late 1980s by Lee and Goldman and other associates. And it's been found out recently that it may be specific for general surgery, orthopedic surgery, and so on. But patients who have more specific risks, in particular patients undergoing lung resection, don't seem to be as well stratified using RCRI. So colleagues of mine in Spain and Italy developed the thoracic RCRI, a variation of the RCRI, which uses a score including the extent of lung resection, coronary artery disease, cerebrovascular disease, and kidney disease to create a new scoring system. And this is then used to assess which patients require additional evaluation of their heart through an algorithm, as you can see here. And this helps to stratify a patient's risk from near zero for the lowest risk category to near 15% for the highest risk category. So this is likely going to replace RCRI in the near future for assessing cardiovascular risk for patients undergoing major lung resection. The European Respiratory Society, European Society of Thoracic Surgeons, now the American College of Chest Physicians, have all undergone changes in their guidelines for pulmonary assessment of patients undergoing major lung resection. This is the algorithm that was published last month from the ACCP group. So we start out with low-risk RCRI or THRCRI, and then move on to standard evaluation for patients undergoing major lung resection, measurement of spirometry and measurement of diffusing capacity, and then routine calculation of the predicted postoperative values for both of those. And you can see that when there are increased risk levels, as indicated here, we do either low technology exercise test or high technology cardiopulmonary exercise test to make the final determination of levels of risk. And this is something that we're using commonly, I wouldn't say routinely, but commonly in our evaluation of patients. And this is now the peak VO2 is essentially the final arbiter of the level of risk posed by some of these patients. And so for us, a prohibitive cutoff is less than 10 ml per kilogram per minute or less than 35% of predicted. And we'll refer those patients for other treatment modalities. It might be a simple wedge resection of the lung for peripheral cancer. More commonly, it's SBRT. And you'll be hearing a lot more about that, I think, from Dr. Liao in a few minutes. So it's a little bit complex, and we oftentimes will have this in front of us when we're making decisions about patients in order to provide them with an optimal pathway towards the most effective therapy. So some other aspects of risk assessment for surgery. Show of hands, and how many people think the increasing risk should be in this direction here? Go ahead and raise your hands, don't be shy. Well, I'll show you some information that suggests that maybe the risk increase is going the exact opposite direction. So these are data from our institution over the last 10 years or so. Now, this isn't just lung resection, but any major thoracic procedure, so it could be thymectomy, esophagectomy, major lung resection. You can see the outcomes of those operations: pulmonary complications, cardiovascular complications, operative mortality, any major complication. And as we move from normal weight to overweight, obese, and extremely obese, the risks actually decrease. So this is the so-called obesity paradox that is present in thoracic surgery. It's been documented in cardiac surgery. It's been documented in heart failure, heart attack, a variety of ICU conditions. It's not well understood why this exists, but there's presumably something to do with adiposity that is a protective factor. And the other thing that's important to notice is that patients who are underweight are at the highest risk. And this is something I think that's maybe generally underappreciated, at least in the surgical community. So these are data that I'll be presenting in Vienna in a couple of weeks from now, looking at pulmonary complications specifically in patients undergoing major lung resection for cancer. And you can see that if we standardize the odds ratio for patients who are underweight, all of the other patient groups do much better than that to a very significant degree. And if you look at the relative incidence of complications, the underweight patients at least double that of the normal patients. And there's a general decline as the BMI degree increases here. So I think this is a very interesting area for further exploration. I think using BMI is just a surrogate for some other underlying factor. Certainly there are patients who are very muscle depleted but obese, who are probably at increased risk compared to those who are obese without muscle depletion. So we need to have better metrics for determining levels of risk, not based just on BMI, but perhaps on the presence or absence of sarcopenia and so on. Now, another thing, in addition to using lung function tests just to look at acute morbidity and mortality, these are data that were presented from our institution in June, illustrating that looking at these PPO, predicted postoperative values for spirometry and for diffusing capacity, it's also an independent predictor of long-term survival. This is in addition to looking at cancer stage, age, coronary artery disease, kidney disease, and so on. And so part of the risk assessment, part of the algorithm for making recommendations to patients is going to need to evolve past looking at acute complications and looking at long-term outcomes for patients based on factors such as these. One of my colleagues in Italy has just recently developed this survival aggregate score, which is a little bit of a crude model right now, but I think that refinement of this may be quite useful in the future, looking at certain elements of the SF36, diffuse capacity and age, and predicting long-term survival is a better means for advising patients on the type of treatment, the extent of surgery, and so on that they should undergo, not just at the outcomes after 30 days or, in some cases, 90 days. So this outlines to some extent where we are in terms of all the data that are collected about risk factors for lung resection. So some physiologic and biologic variables, institutional variables, surgeon variables, all in order to quantify risk for undergoing major lung resection. It used to be in the old days, in the 19th century and for most of the 20th century, that it was the surgeon's judgment that was the only thing that was used. And currently, we're sort of now lacking measures of the accuracy of physician judgment in making recommendations for major operations like lung resection. This is a study we published just a few years ago trying to assess the accuracy of physician judgment in patients undergoing major lung resection. So what I did was to take 100 vignettes of actual patients who had major lung surgery, and of course I knew what the outcomes were, but the people participating in the study did not. And looking just at the vignette data, asked the participants to score relative risk. And you can see the overall accuracy for trainees, 50%, so they had a 50-50 chance of being right that the patient had a major complication or not. And experienced thoracic surgeons were correct only less than 60% of the time. And you say, well, obviously the participants didn't have a chance to look at the patient, observe them, the so-called eyeball factor. So what we've done is to try to evolve methods of evaluating how much the eyeball factor enters into risk estimation. And one of the factors that enters into this so-called eyeball factor is frailty. This is a pretty hot topic now. The frailty phenotype was described just over a decade ago, and it's been found to be a very useful and independent predictor of both short-term outcomes after major surgery as well as long-term survival. So the phenotype is illustrated here, 3 or more of these traits. And one that's not listed here, which some people don't include in frailty, is dementia. It could be a separate indicator of its own for short-term morbidity, mortality, as well as long-term survival. So in order for us to do some research on this, we created another set of patient vignettes and asked both attending surgeons and senior-level trainees, fellows in cardiothoracic surgery, to score risk based on these vignettes. Then we showed them a video. So I had made 60 or 70 videos using standardized patients who we trained to exhibit various levels of frailty, and then exposed the participants to a random choice of these videos. One would either be a very vigorous person or one a very frail person, and then asked them to score risk again. And what we found out was, so we have a couple of things. This is a little bit complex. There are a group of frail videos that were viewed combined with the vignettes, or vigorous videos combined with the vignettes. And then the vignettes themselves were of either very low risk, moderate risk, or high risk patients. And what we found that is if there was concordance, frail video with a high-risk patient, there wasn't much change in the risk score for those patients. But when there was discordance, a frail video with a very low-risk patient, there was a substantial change in the risk score, and this was true of both the trainees and the attending surgeons. Similarly, if we look at vigorous videos, didn't change the patients who had low risk, but patients who had a high risk vignette, but a vigorous video, this substantially reduced the risk score for those patients. So overall, there's the eyeball factor, based on this, accounts for something like 15% change in the risk scores. And we're going to pursue this with additional evaluations looking at gender, looking at age, and so on, to try to get a better idea of what these clinicians see when they look at a patient and how it influences their estimates of risk. Now, as it turns out, there's a pretty broad disparity in what are considered acceptable outcomes comparing patients and physicians. So as a surgeon, I think a postoperative pneumonia is a disaster. Having to bronch a patient with respiratory failure postoperatively is a pretty big deal. Having a patient on a ventilator for a month or having a postoperative myocardial infarction, I would consider a failure. Yet more than 50% of patients think, well, those are acceptable as long as I'm not oxygen dependent when I get home, as long as I can exercise, as long as I don't have the need for assistance with activities of daily living, and so on. So there's these malaligned concerns between the surgeon and the patient. Surgeon, complete resection is important. Patient doesn't care about that. Surgeon, low morbidity is important. The patient's more concerned about pain than morbidity. Rapid discharge, extended stay is okay, et cetera. I saw something online about this over the last few days. Did you guys see this about this woman who was in the hospital in New York City for over 20 years? She had sold off her condo overlooking Central Park. This was her view from her hospital bed. And they were fleecing her essentially for her millions of dollars. So extended stay, I'm not talking about 20 years. I'm talking about an extra week or something like that. So another interesting aspect is that patients tend to want to be active about their management of cancer. So this is an interesting thought study that was performed within the last decade or so. The scenario was that a patient was supposed to presume that they had a moderate risk cancer, diagnosed with cancer, could be observed, could be treated surgically. And there were two scenarios. One was that the chance of death from active treatment was 5% compared to the chance of death with no active treatment of 10%. How many would choose active treatment in that scenario? Go ahead. No? Nobody wants active treatment if it's going to double your life expectancy? So 90% of the people chose surgery. Faced with the other scenario, 5% chance of death from doing nothing, 10% chance of death from surgery. How many would choose surgery in that situation? 2/3 of the patients did. So what this indicates is that patients with cancer would like to be active in managing their cancers, even if that includes surgery. This was a much stronger predilection for surgery than for things like chemotherapy or radiation therapy. So if the outcome is going to be achieved actively, that's seen as a better course of action than if the better outcome is achieved passively. So it's incumbent upon us, the caregivers, to assist patients in making more appropriate decisions about their treatment. So, a lot of times we think to a hammer everything looks like a nail. So for a surgeon, for example, surgery is always the answer. And to the patient coming to the surgeon, they're willing to accept that assessment. We have to be a lot more careful in how we assess and advise patients based on some of the psychology that may be not obvious to all of us. So let's talk a little bit about personalization of surgical therapy for patients. You're all familiar with a couple of the options for major lung resection, lobectomy, bilobectomy versus pneumonectomy. Mortality rates are acceptable, not great, but acceptable, and major complication rate is manageable. Compared to pneumonectomy, mortality rate is substantially higher, major complication rate substantially higher. So there are ways of avoiding pneumonectomy, doing parenchymal sparing operations we'll talk about primarily here. Ways of avoiding doing lobectomy with segmental resections, taking out anatomic portions of the lung, but less than a formal lobe. Doing non-anatomic resections versus anatomic resections, and using something other than surgery, such as SBRT. So sleeve resection is supposed to be in the armamentarium of the typical thoracic surgeon these days. About 10% of the operations should probably be sleeve lobectomies. You can see removing a lobe here of a very proximal lesion, sparing the other two lobes, reanastomosing the bronchus to the main bronchus. Here is a typical scenario for that. Now, if you look at the outcomes of these operations, so this looks at post-operative mortality, the odds ratio substantially favors sleeve lobectomy compared to pneumonectomy. And if you look at long-term survival for these patients, the hazard ratio of mortality substantially favors sleeve lobectomy compared to pneumonectomy. Part of the reason may be the additional loss of FEV1 and diffusing capacity that is engendered because the patients undergo a pneumonectomy as opposed to a smaller operation. So you can see the difference in survival outcomes, almost 20 percentage points, almost a doubling of survival if you spare lung parenchyma compared to doing a pneumonectomy. And some work we did not too long ago also demonstrates that this is a very cost-effective measure when you compare pneumonectomy to sleeve lobectomy. So one of the other things about doing smaller resections is the changing landscape of lung cancers that we're seeing. And this transition has been happening for the last 10 or 15 years, but it's, I think, increasing exponentially. Even within the last 5 years, we've seen changes in the distribution of adenocarcinomas versus other non-small cell cancers, a growing incidence of minimally invasive cancers, a shift from central to peripheral cancers, and a growing disposition for surgeons to perform smaller operations as opposed to standard resections. This just illustrates a change in the last decade or so. Early in the 2000s, substantial survival advantage for lobectomy compared to lesser resections. That difference has now been almost completely abrogated. Part of this may be increasing skill of the surgeon in selecting patients for lesser resections. Maybe it's related to the difference in aggressiveness of the tumors that we're seeing. This is being pursued actively, looking at wedge resection, segmentectomy versus standard lobectomy in CALGB 140503. An attempt was made to compare lesser resection to SBRT using ECOSOG Z4099. That had to be closed due to inadequate accrual. So we're going to have to base most of the information we use for decision making on institutional reports and perhaps reports from the national databases until the data from 140503 mature. One of the major changes that we're seeing with regards to this change in histology and behavior of tumor is the new classification of adenocarcinoma. So they have these major categories: pre-invasive lesions now versus minimally invasive adenocarcinoma versus invasive adenocarcinoma. You can see representative images of those here. And these have a lot to do with predicting behavior of the tumor and create challenges for surgeons and oncologists in how to best manage these patients. So if we look at, for example, the micropapillary content of tumors divided into a score category of less than 5 versus greater than 5, you can see if you do a lesser resection for a patient with a so-called high-risk tumor, the rate of local recurrence is substantially higher. And whereas if you do a standard lobectomy, regardless of the aggressiveness of the tumor, recurrence rates are quite low. So it's maybe incumbent upon us to subclassify these minimally invasive tumors in the future based on not just their gross histology, adenocarcinoma versus squamous cell cancer, but the other more specific characteristics of these tumors. You can see the lobectomy patients here who have scoring patterns for the micropapillary content all do pretty well, whereas if the lesser resections are done in these dashed lines here, the more aggressive the tumor, the increase in incidence of local recurrence. So we have to be quite careful about using these lung-sparing operations depending on the histologic findings in the patients. The approach to resection has changed considerably in the last 15 years. I'd say at about that time, the majority of surgeons were moving towards muscle-sparing operations, but thoracotomy. For the last 10 years, a large proportion of operations have been done using minimally invasive surgery, VATS, video-assisted thoracic surgery. And now there is a small trend, at least, moving towards robotic major lung resection rather than VATS. So initially this is just me, but thank you very much, Ray. Initially we used these minimally invasive techniques for small cancers. Now we'll use them for pretty much cancers of any size. They originally had to be peripheral. Now they can be central cancers, or they used to have no adenopathy present for us to proceed with those, and now higher adenopathy and even mediastinal adenopathy are appropriate situations for these minimally invasive techniques. These data from the STS database show the increase in incidence, dark gray here, of thoracoscopy versus thoracotomy for doing major lung resection. So 10 years ago, 15%. Now almost half of the patients in the database are undergoing minimally invasive surgery. In our practice, we're at 65% of all of our lobectomies are done using minimally invasive technique. And you can see some of the advantages of that. The incidence of pulmonary complications increases linearly with a decrease in FEV1 for thoracotomy patients, whereas there is advantage in the thoracoscopy patients of a reduced risk of pulmonary complications, even those with very severe emphysema. And the other thing I'd like to point out is that these changes take time. So this is a study of the development of proficiency in doing VATS lobectomy. So we think in surgery of levels of accomplishment for surgical procedures. We start with a surgeon who is naive, and then a level of competence. Competence indicates indicates effectiveness and safety. So not too many complications, get the job done. When we're talking about moving to proficiency, then we have to be efficient, reducing the amount of time to perform the procedure. And we have to be, efficient, and we have to be consistent. That means the amount of blood loss has to be small and stable. The amount of time it takes to do the operation has to be relatively stable. And this just illustrated the development of proficiency for two surgeons who started out at zero experience with VATS lobectomy. And you can see it takes somewhere between 110 to 160 or so operations to develop proficiency in terms of operating time. We never reached efficiency, we never reached consistency for blood loss, length of stay, and so on. So, at least a couple of hundred procedures is required to achieve real proficiency in doing these higher level operations. So if you can imagine, if the volume in a hospital or the volume of a surgeon is relatively low, it may take a decade for them to achieve a level of proficiency that you as the patient would like to see. A number of advances in surgical technology have been described in the last few years. So now we're using light filters and vital dyes to help enhance imaging when we're doing these minimally invasive, and particularly their robotic operations. You can see a standard lymphovascular plane here using the robot, and when you give a vital dye and filter the light appropriately, that makes the blood vessels light up very brightly and distinguish it from the surrounding fat. This is a way that we can increase the safety of these operations done. So the technology is not just gee whiz, but it actually has real advantages for patients. You can see identifying structures, blood vessels with Doppler probes, structures within the lung parenchyma using ultrasound probes, identifying with radiology and fiducial marking small ground glass opacities that would not be palpable or visible on the surface. And all of these will be enhanced using robotics from improvements in the technology that the robot has to offer. You can see some of the advantages here of using the robot. Greater articulation, 3D visualization, substantial magnification, stabilization with relation to the heartbeat, for example, elimination of resting tremor in the surgeon's hands, all improve the accuracy of dissection. There are, of course, disadvantages to this. This is the early stages, almost prototype stages of robotics for doing these major lung resections, and we need to get to 2 or 3 generations of design further before I think this is going to be widely accepted. There are substantial costs. Robots individually are $2 million. Disposables are quite expensive. Time to set up in the operating room, also quite expensive. The other problem is that when I'm at the console doing the actual operation, I'm using literally 4 fingers, index finger and thumb, and everybody else in the operating room is standing around with their arms crossed, watching this on a screen. There's almost nothing for them to do for hours at a time, so we may have to redesign what everybody's doing. I mentioned at dinner, I think the other night, that I should go off and go get a cup of coffee while the robot is doing the operation. That's about 20 years down the line. The outcomes are satisfactory currently. There's no apparent additional risk to using the robot. The complication rate, mortality rate, and so on are very similar to VATS operations and to open operations. So it's an acceptable technology. To make it very valuable, we need to make it better than what we currently have. So that's why we need the next 2 or 3 generations of robots for moving ahead. This sort of summarizes what my view of personalized surgical therapy includes. We talked about the approach and extent of resection, improvements in physiologic assessment, measurements of long-term survival, appropriate staging, and there are a lot of efforts ongoing determining how well quality of life impacts outcomes of surgery and how we can improve postoperative quality of life. And all these then reflect on personalized recommendations and personalized choices that individual patients can make. I'll just briefly now summarize some of the changes in surgical practice that have occurred even over the last 10 or 15 years. So when I started practice, surgery was the primary therapy for most patients with lung cancer. Now it's the primary therapy for only very early stage patients. It was the primary means of staging. I guess I had started training before PET scans and, believe it or not, before CT scans. Now it's a very secondary means of staging. Salvage resection was uncommon. Now we're increasingly using salvage resection after patients have undergone definitive chemoradiation therapy for their tumors. And I think what reflects what we're going to see from our next 2 speakers, the surgery usually encountered a rare need for reintervention in patients. And now with these personalized therapies that we have, particularly with the shifting genomic signature of patients' lung cancers and ultimately failure of one regimen, the need to start another regimen, the requirement that we have additional information that characterizes the tumor at that point in time, we're finding ourselves reoperating on more and more patients more and more times just for tissue to better characterize tumor markers and so on. So in summary, the staging algorithms are evolving towards less and less invasive techniques. Our ability to assess surgical risk is improving. There's a lot of ongoing research regarding that. We talked about some of the expanding types of surgical options and the new technology to facilitate that, and the changing nature of surgical practice, all of which are aimed at personalizing surgical therapy for lung cancer. So I think I'll stop there, and I think we may have a few minutes for any questions before we have the panel discussion. Thank you very much for your attention. Don't be shy. Any questions?
I have a question. You mentioned the prognostic, pre-surgical prognostic scoring that your colleague in Italy had developed and used a term that I was unfamiliar with. I think it was SF36 or SAF36.
Well, the short form 36 is just a measure of physical, mental, emotional, functional ability, and this included just the physical component of that. So it's relatively easy to assess in probably a three-question questionnaire.
Ask one more question. It was very interesting when we talked about staging and the tools available, the EUS, the EBUS, traditional mediastinoscopy, VATS. What makes you choose a mediastinoscopy over an EBUS in 2013?
So the algorithm begins with doing EBUS/EUS, and our interventionalists in GI and pulmonary are developing the skill sets for each of them to do both of those procedures, so it's a little bit now cross-specialty. When the staging is incomplete, for example, they fail to sample certain nodal stations, or when it's inconclusive, particularly in the face of discordant findings on CT or PET, then we'll do mediastinoscopy. We're also having some issues right now, and I think this will be sorted out in the next few years with regards to vendors and determination of tumor markers. And a lot of times they need a larger quantity of tissue than a fine needle aspirate will provide. So some centers say they need 50 cells, others say they need 1,000 cells. So the fine needle aspirate can usually provide sufficient for those high-level performers, but for most of the performers right now, they need more tissue than that, and so formal biopsy is usually more effective for that.
In the operable disease, including from all the way from stage 1 to stage 3A, I see that on your algorithm, stage 3B is the one you don't usually do the surgery. So do you do surgery like a combined induction chemo followed by surgery on all stage 3As?
Vast majority. If we think that they're technically resectable, then we'll aim towards induction chemo and RT, and followed by surgery. There are some patients who have such extensive extranodal spread, matted adenopathy, that it's unlikely that they'll become candidates for surgery. Some of them will have encasement of the artery, for example, which may preclude safe resection or may require a resection that's too great to be permitted because of their underlying pulmonary function. But the basic algorithm is to be aggressive in stage 3A patients, so treat them, and usually pretty high dose radiation, 66 gray, for example, before the resection.
So you actually resect those patients who had a definitive chemoradiation as
Well,
neoadjuvant treatment?
So it's neoadjuvant, it's definitive levels, but it still permits safe surgery if it's done in an appropriate time frame.
Thank you.
Two quick questions. In your last slide, you said primary therapy for T1A and T2A, but you left out T1B.
I think the intent of that was to say exclusive therapy, and so now some T1Bs, particularly those that are 4 centimeters or greater, have been found to benefit from postoperative adjuvant chemotherapy. And so T1A and would be the exclusive province of surgery if the patients are operable right now, whereas most of the other stages would benefit from either preoperative or postoperative and other additional treatments. Certain categories of T1B, yeah.
And the robotic surgery, is this, of course, there's big controversy in the OBGYN also, whether it's beneficial or not. Are you using it to try and salvage or try and do definitive therapy in patients with marginal lung function? Is that how you use the robotic?
So we think of minimally invasive surgery, which could be VATS or robotic, as being potentially advantageous in patients who are at very high risk but not prohibitive risk because of the likelihood of preserving the immediate postoperative lung function and getting them through the operation safely. So if you look at patients who have a thoracotomy, particularly those undergoing major lung resection, the spirometry values decrease by almost 80% in the first 12 to 24 hours after the operation. They improve back to about 50% of baseline by a week, but those first few days are very tenuous. And it's very likely that using a minimally invasive approach as opposed to a thoracotomy can substantially reduce that initial loss in functional capacity and help prevent complications. The robot isn't any better than VATS in trying to reduce risk in that way. But yes, I think some people are now using it, including me, to expand the population of patients who are eligible for surgery because of the perceived reduced perioperative risk. Yeah.
Is there any situation when you would consider surgery for metastatic disease, especially the younger patient that may have a stage 1 lung cancer, no mediastinal node, but a solitary brain metastasis?
The answer is yes. It's not a simple question, though, as you, I'm sure, realize. And evidently you missed the first symposium, which is on management of metastatic disease. So one of the controversies in surgery and oncology today is whether or not resection of metastatic disease, and this focuses mostly on isolated lung metastases, actually provides any benefit to patients, or whether the perceived improved survival is more a function of patient selection and tumor biology. There are a number of anecdotal reports indicating that isolated other organ metastases, such as a single adrenal met without any evidence for other spread, so the patient would otherwise be early T-stage N0, a pretty good survival outcomes in those patients. The typical one is a patient with 1 or 2 isolated brain metastases, otherwise stage 1 disease. 5-year survival for those highly selected patients is about 25%, which is very good. We're learning a little bit more about lung metastases and their biology. So at my institution, Sam Hellman and Ralph Weissenbaum sort of coined the term oligometastases about 12 years ago, I think. And Ralph has led an effort in the last year or so to identify signatures of microRNA which predict outcomes for individual patients and behavior of these tumors. So with certain of these microRNA signatures, one cluster, those patients will have near normal life expectancy. There's an intermediate cluster that's not very predictive, and then the very poor performing cluster that has like a 6-month survival rate. So it may be that as our ability to molecularly characterize the metastases improves, we'll be much better able to select more appropriate therapies for these people. But from a clinical perspective, in highly selected patients, there is some apparent benefit to resecting oligometastatic disease and treating the primary tumor for patients with lung cancer. Yeah. Yes, in the back.
Could you please say more about the relationship of why underweight patients have more pulmonary complications and surgical morbidity? Is it a marker for low albumin or malnutrition, or what do you?
So we don't understand for sure. The studies that have been done are unable to differentiate between chronic low underweight and acute weight loss culminating in underweight. Presumably, most of these patients are sarcopenic. Presumably, it's a marker for impairment of their immune system, which has a lot to do with regulating cancer cells. Certainly, patients who are sarcopenic are not as effective in doing breathing exercises postoperatively. They'll have weakness of their muscles of respiration, including the diaphragm. And I think those are the two major underlying reasons why they get into trouble, is the immune suppression and overall weakness. I've answered every question on everybody's mind. Well, I'm sure there'll be more when the case presentations begin.